Welcome guys to the second part of discussion of general medicine question paper from the INI-CET SS. So I've discussed previously 15 questions from this exam, recently concluded exam, and we're going to discuss next set of 15 questions now. Now before that, I would like to obviously tell about or say promote about this part, this Harrison revision course. Like with initial success of previous year, we are again starting this Harrison revision course from May 10 onwards. Our idea is to complete Harrison in the form of question and answer session in the form of a question discussion of complete Harrison within 6 month period. Okay, this is our main idea, main motto. Nothing else, nothing less than that. So this is the complete schedule. So we'll have at least 3 tests in every week, starting from the 10th of the May and this first week and up to December 10th. So as NEET SS exam date has arrived, NEET SS exam date has arrived. Therefore, we have changed the schedule a little bit from if you see the previous schedule currently and the new schedule. So we have 5 GT and our target finishes within 8 December. Keep you in hand at least 2 days free time before the exam, as well as if you see complete course is finishing by 1st of December. Okay, so whole Harrison is finishing by the 1st December, and who are our target is obviously NEET SS exam, or residents who do not get enough time to study the complete textbook. You see, it is a very difficult language, and secondly, no resident is free enough. No senior resident, other the resident one or second year or third year, are always busy in words, always busy in their duty, so they do not get enough time to complete edition. Therefore, completion with some bit of exercise in the form of question answer make it easier. So our target are NEET SS exam candidates or residents, whether first year, second year, or third year, or final year MBBS student who want to complete the Harrison. Okay. All right. Now, other few queries have been raised for this quiz or this question and answer discussion session, Harrison revision module we are going through. The thing is that lot of you have asked who is preparing the quiz. No, I am not alone preparing the quiz. There are different people, different consultants from different stream, like gastroenterologists, cardiologists, who are there in this team along with us. We are working together to form this MCQ from Harrison chapter wise section. Okay, and every question will be from the Harrison only, and we will obviously provide notes for easy revision from it. Now, those who want to join obviously can join from the link in the description. Now, coming to the question. So it says, this first question here, you can see it says, a 21-year-old male is presenting to the clinic with complaints of red colored urine. So there is red colored urine. That is the complaint of this male. He currently has history of sore throat and a low grade fever for 1 day. And there was low grade fever 2 days back and sore throat for 1 day. So what are the history points again? History point here we have sore throat for 1 day. There was fever. There is fever 2 days back. Okay. 2 days back and currently presenting with red urine. So what does it signify, this red urine along with fever? It is nothing, we call this term medically to be symphyrangitic hematuria. That is hematuria occurring along with symptoms of pharyngitis. Okay. Now on examination, his blood pressure is normal, 120/80 is normal, and there is no evidence of pedal edema. Laboratory investigation reveals urinalysis RBC cast present. That is 2 plus proteinuria is present here, and serum complement C3 is normal, C4 is normal. Likely diagnosis. So correct answer here is actually IgA nephropathy, but a lot of you have make mistake and marked it as post-infectious glomerulonephritis. It is not actually. Why not? Because here hematuria occurs in hand almost acutely within 1 to 3 days with sore throat. What happens in post-acute glomerulonephritis or post-infectious glomerulonephritis? Here hematuria will occur usually 1 to 3 weeks, 3 weeks after pharyngitis. Okay, so there is a latent period after which it happens. Now, regarding Alport syndrome, Alport system is very rare here. Why rare? Because Alport is mostly hereditary. So in question STEM, there will be some pointers to discuss or make it like a hereditary syndrome. Then there is what additional features in Alport. Alport is additionally will have along with it history of hearing loss, or any sort of eye abnormality. Okay, why not ATN? So in ATN, there is one other point which will be there along with ATN here is that cast will be present, but cast will not be usually RBC cast. RBC cast suggests glomerulonephritis rather than tubular necrosis. So it is most likely glomerulonephritis. And RBC cast is present here, but in case of acute tubular necrosis, mostly the cast which would remain present would be muddy brown cast. Okay. So the answer here is nothing else than IgA nephropathy. Now, if you check what Harrison says, now you can see here in the Harrison, it has been completely mentioned. In PIGN, the post-infectious cases, it should be distinguished from infection-associated glomerulonephritis, and as well as it should be distinguished from symphyrangitic hematuria. So, what is symphyrangitic hematuria? It is a glomerular syndrome that frequently produces a heavier excretion of red blood, and and in symphyrangitic hematuria, it occurs simultaneously with 1 or 3 days into viral pharyngitis. It is most often related to IgA nephropathy. Okay. Another point from here you should know, IgA nephropathy, that both IgA nephropathy and PIGN, in the both the cases, C3 complement gets deposited. C3 complement gets deposited in both of the cases, but only PIGN is associated with low complement level in blood. Okay, all right. So here answer here is IgA nephropathy. Okay. Now coming to the next question. This is little bit of an easier side. So 65-year-old male admitted in ICU with septic shock associated with acute kidney injury. Despite receiving an initial bolus of 30 ml per kg of IV crystalloids, so it is the first step in case of sepsis, in case of management of sepsis according to surviving sepsis guideline, to give a fluid bolus 30 ml per kg of IV crystalloids. He remains hypotensive. Which of the following is the most appropriate next step in management according to guidelines? So nothing else they want to know about you. Examiner here wants to know from you is that how to manage or how to resuscitate in sepsis. Okay, in sepsis. So thing is that in case of sepsis, best marker is always dynamic indices over static indices, and noradrenaline is the first choice vasopressor in all of the cases. So option B will be correct answer here. Okay. Now, rationale behind this to be correct and evidence-based discussion. For this purpose, if we check CRT, why CRT? Never CRT will be the first choice. So even there are a lot of studies which has shown that early initiation of RRT does not improve the survival or kidney recovery compared to watchful waiting. Okay, so RRT should be reserved only for life-threatening complication. Say there is refractory hyperkalemia, say there is severe acidosis or refractory fluid overload which is not getting managed with fluid therapy. Here, patient is already dehydrated. There is acute kidney injury, but patient is dehydrated. First, manage the dehydration, then only we will consider for other therapy. Okay. And also, the question doesn't mention about any other need or indication for renal replacement therapy. Now, aim for central venous oxygen saturation more than 70% to guide aggressive fluidization. No, it is not followed currently. It was standard once, it was considered as a standard therapy once said decades earlier. However, there are multiple trials. If you just want to know the name of the trial, there are process trial, arise trial, and promise trial that demonstrate that bundle approach doesn't always help in survival benefit over the standard high quality care. So this SCVO2 guided therapy is not the standard in current according to current guideline. Now, according to option D, aim for central venous pressure of 8 to 12 millimeter of mercury to guide further fluid. This is also not the answer because CBP, what is CBP? CBP is a measure of pressure. It is not the measure of the volume. So normal CBP will never guarantee fluid responsiveness. It is used as a target earlier, but currently it is discouraged. So, which is best? Best indices is obviously dynamic indices. What are the dynamic indices? It can be passive leg raising test. It can be passive leg raising test. It can be pulse pressure variation, or it can be stroke volume variation. Okay, and obviously NORAD is the first choice pressure in case of septic shock. Now, coming to the third question, it was the only image based question from this paper. So this was also an easy question. So you can see clearly what is it. It is Eschar. In which disease Eschar is seen? Eschar is seen in scrap typhus. So you can also see a disease also mentioned about a forest officer presenting with 5 days of high grade fever, headache, and generalized joint pain. So there is arthralgia and fever, and obviously headache, and there is forest officer. So residing in forest. On physical examination, painless, cigarette burn like necrotic lesion with a black crust is noted. So it is a description of Eschar. Likely diagnosis scrap typhus, which is caused by Audentia schutzruhmasi. Even Harrison says, you can see here, Eschar is usually seen. Eschar is usually seen in the part where the sugar has fed. Okay, the larval stage of the Audentia schutzruhmasi has fed. As long as there is regional lymphadenopathy, so nearby zone of this eschar, which it drains, there is lymphadenopathy and maculopapular rash. These are the usual signs. These are the usual signs of scrub typhus. Okay, all right. So answer here is scrub typhus. Now coming to the next question. So patient here has undergone splenectomy. Okay, so so here they are asking about who are at increased risk of developing infection due to which organism. So splenectomized individual are at increased risk of developing infection due to which organism? The answer is nothing but the one which are capsulated organism. Capsulated organism. For mnemonic purpose, you can remember with the name SIN. SIN are the capsulated organism. So SIN causes OPSI or opportunistic or overwhelming post-splenectomy infection. Okay, overwhelming post splenectomy infection. Okay, so what are the sin? What are the sin? Sin is streptococcus. Streptococcus I is influenza. Which influenza? It is Haemophilus influenzae. Haemophilus influenzae. L is Neisseria meningitis. Okay. So these are the usual three capsulated organism which plays a role in causing infection in post-splenectomized individual. Why so? Because spleen plays a major role in clearing the encapsulated organism, and it also produces spleen is the organ. It clears the encapsulated organism. It clears the capsulated organism. It also produces IgM. Okay. It also produces IgM, which helps in opsonization of organisms, this capsulated organism or foreign bodies. Therefore, as in splenectomy, there is decrease in IgM, and due to absence of spleen, there is no role in clearing of this organism. So there is high chance of this infection. Okay. Now, among these three, if question is asked, which is most common is streptococcus. Streptococcus. Okay. Now, what is the presentation? It can present like septic shock, DIC, or sometimes even death. Okay. All right. So answer here is Streptococcus pneumoniae. Streptococcus pneumoniae. So you can see here from the Harrison only, splenectomy increases risk for infection with Streptococcus pneumoniae, Haemophilus influenzae. Okay, all right. So it also says, therefore, in patient who are splenectomized, it becomes pertinent and very much essential to go for vaccination. Which vaccine? That is pneumococcal conjugate vaccine. Okay, or there is also PPSV vaccine for pneumococcus. All right. Okay. Now coming to the next question, which of the following is not true about type 2 lepra reaction? You see there are two type of lepra reaction. Type 2 you often call to be erythema nodosum leprosum. So type 2 and type 1, if you see want to see the difference, type 1 versus type 2. So type 2 what we call it to be erythema nodosum leprosum. So it is nothing but the immune complex deposition disorder. So immune complex deposition is there. So therefore it is type 3 hypersensitivity. Type 1 is a delayed hypersensitivity. It is a type 4 hypersensitivity. Okay. Okay. How do you remember? You remember the rule of 5. So 1 plus 4 equals 5 and 2 plus 3 equals 5. So here rule of 5 is followed. So type 1 is type 4 hypersensitivity, type 2 is type 3 hypersensitivity, type 3 is immune complex deposition, type 1 is delayed hypersensitivity. So usually old lesions are inflamed in case of type 1 because it is delayed. So old lesions are inflamed here. Whereas due to immune complex deposition, there is new nodule formation in type 2 hypersensitivity. Due to immune complex, systemic symptom will be very high here, very high here, and here there will be mild symptom present. Okay. Nerve involvement will be less prominent in case of type 2 reaction, whereas severe in case of type 1 reaction. Treatment here is steroid. In type 1, treatment is steroids. In type 2, treatment is usually steroid is given, but thalidomide is also approved for this condition. Okay, all right. Now, looking into this question, so which of the following is not true about type 2 leprosy reaction? So type 1 is delayed, so it is more of a chronic symptom. Type 2 is acute presentation. It is true. True. Okay. Now, borderline lepromatous and lepromatous leprosy are high risk. Yes, yes, they are high risk. Usually, borderline lepromatous and lepromatous leprosy are high risk, uh, high risk in case of type 2 leprosy reaction. Okay. Then thalidomide is a drug of choice. Yes, thalidomide is a drug of choice, especially in the severe erythema nodosum leprosum. It is the drug of choice. Alternatively, obviously, we can go for steroids and clofazimine. Okay, or these are alternative choice. Now, regarding seen in pre-existing skin lesion, no, this is false. It is seen in case of type 1 lepra, not in type 2 lepra. Okay, so as you can see here from the Harrison only. So type 1 leprosy reaction. So here, this is the type 1 leprosy reaction. There is increased inflammation of the existing lesion in the type 1, not in type 2. And type 2, there is erythema nodosum leprosum with pustular lesion. There are multiple lesions present, and these are nodular lesions. These are nodular lesions. Okay, these are nodular lesions, as you can see here. All right. Okay, so that's regarding this question. Now coming to the next part. So regarding orophyretinib. So this is a newer question based on the recent updates regarding orophyretinib. Which of the following statement is incorrect? So even if you don't know most of the part regarding this, what you can guess, it is a tyrosine kinase inhibitor, tinib, right? It is a tyrosine kinase inhibitor. So most of the tyrosine kinase inhibitor, that the thing you should know, is metabolized by CYP3A4 enzyme pathway. All right. Then it is considered safe for use during pregnancy. So to level some drugs safe for pregnancy, what you need meta-analysis, you need randomized control trial in a pregnant population, and then only can level itself to be safe or category A. Until and unless there are not enough study, most of the drug either they're teratogenic or they're category C. Okay, they are not completely safe in pregnancy. Do you feel tyrosine kinase or newer generation or complete newer update drug will be something which will be studied in pregnancy? Absolutely not, right? So this tyrosine kinase is not safe for use pregnancy for current standard. There is no enough study. Even if you should know, most of the tyrosine kinase inhibitor has teratogenic potential. Okay, so so they are often considered category D or category X. Even effective contraception is mandatory during the use and after the months after the treatment with this kind of drugs. Okay. Now these are metabolized by CYP3/4 and therefore they should be avoiding ketoconazole and rifampicin while the patient is on erlotinib because it is going to CYP3/4 pathway only. GI side effect, almost all drug in the world has GI side effect, but this first generation tyrosine kinase has much more prominent GI toxicity. So there was much more prominent nausea, much more prominent diarrhea due to this inhibition of EGFR in the gut lining. Okay, and endocrinal growth factor receptor in the gut lining. So all of this has a side effect of GI toxicity resulting into diarrhea and nausea. It specifically targets C797S mutation that causes osimertinib resistance. In fact, this drug is currently researched, orofiditinib is currently researched in a case of osimertinib resistance, so that we can go for with this drug like orofiditinib. Therefore, option D is also true. Correct answer here is it is not considered safe in pregnancy, so B is incorrect statement. Okay. Now coming to the next question. So they have asked about types of MI, right? Now before getting into the question only, so let's discuss about the what are the types of MI we should know. Okay. So what is myocardial injury and what is meant by myocardial infarct? So as you can see from the Harrison, the term myocardial injury should be used when there is evidence of elevated cardiac troponin. So when troponin is elevated, cardiac troponin is elevated, what we call it? We call it to be myocardial injury. Now, along with myocardial injury, if there are additional features are what? Additional feature of at least one feature. What are those? Symptoms of myocardial ischemia. Symptoms of ischemia if present, then or new change, in ECG, or QF, or imaging shows loss of viable myocardium or new RWMA. So RWMA or loss of viable myocardium on imaging, or autopsy suggesting of thrombus, autopsy or angiography. All right. So this is the condition when you call this to be. This is the condition. This box when we will call it to be myocardial. This part we will call it to be myocardial infarct. Myocardial infarct. Now this is again classified into multiple types. Now types, what you should know are type 1, type 2, type 3, type 4. Type 4 is again classified into A and B, then type 5. Okay, so type 4, which is again 4A, 4B, and we have type 5. Okay, what do you mean by type 1? Type 1 is the normal one, which you know there is plaque formation or plaque rupture, or there is thrombosis, which result into SS, standard SS, standard STEMI, or standard non-STEMI. So it is a STEMI or non-STEMI, which is a standard SS actually. So which occurs due to plaque rupture or thrombosis. Type 2 usually seen when there is two things. So from 2, remember two things. One is demand, another is supply. So when there is demand supply mismatch, it results into type 2 MI. What is type 3? Type 3, remember 3 letters. It is SCD, sudden cardiac death. When sudden cardiac death is there, and from some way you can prove that it is due to MI, whether autopsy study or something else, in such cases it is type 3 MI. Type 4 and type 5 are reserved for procedures. So procedure related MI are with type 4 and type 5. Now tell me which one will be surgery, open heart surgery, and which one will be PCI. So obviously we have kept open heart surgery for the later classification. So type 5 is post CEBG related, post CEBG MI. Type 4 is post PCI MI. Okay. Now, if it occurs during PCI, it is 4A. And if there is thrombosis of the stent thrombosis, it is considered as 4B. Okay. So that is the classification MI according to new universal definition. Now, if we look into the question again, so let's see what the question step want to say to us here. So as you can see here, a 55-year-old male, 55-year-old male is brought to the emergency with massive hemoptysis and features of hemorrhagic shock. During active fluid resuscitation and stabilization, he develops sudden SOP. So here, patient presented with massive hemoptysis and features of hemorrhagic shock. Presentation was not related to MI, presentation was related to hemorrhagic shock. Okay, it is due to hemorrhagic shock. When during resuscitation, which is one of the important cause for demand supply mismatch, resuscitation, there patient developed SOB, ECG was done, which suggests ST depression in lead VT to V4, troponin to be elevated. So what do we call troponin to be elevated? With troponin to be elevated, we call it to myocardial injury. What do we call when troponin is elevated along with there is symptom or there is ECG change? We call it to myocardial infarct. Okay, so there is myocardial infarct. Now, according to current universal definition, what is the most likely diagnosis? So there are two things happen. Demand supply mismatch is there. Therefore, the answer here is type 2 MI. Okay, so it is most likely type 2 MI. All right. Okay. Now coming to the next question. So a 19-year-old male presents with 24-hour history of periumbilical pain that is now shifted to the right lower quadrant. So basically, we are dealing with the right lower quadrant pain, which is associated with low-grade fever and anorexia. Young male right lower quadrant pain, and we are going to elicit the elusive sign. So what is the most likely diagnosis we are dealing or thinking about? So what is the cause of right lower quadrant pain? Okay, so right lower quadrant pain in young male, first degree that should come in mind is nothing else appendicitis, acute appendicitis. Now, appendix location clinically can be at multiple places. So, to identify which part it is, we can go for multiple maneuvers. So, if it is retrocecal, behind the cecum, it hides behind the cecum, the maneuver that you can go for is Suasen or Iliasuasen. Why it is important? Because retrocecal appendix is usually most often not visible during ultrasonography. Okay, so maneuvers often helps to identify whether there is some sort of tenderness or some there is idea of retrocecal appendix present or not. Then we have pelvic appendix. What maneuver we can go for? We can go for obturator maneuver. Then in anterior appendix, which is the usual location in anterior appendix, we can obviously go for to check McBurney's point tenderness. McBurney's point tenderness. Okay. Now, where is McBurney's point? It is 1/3 point from the anterior superior leg spine to the umbilicus. So when you join this line here, anterior superior leg spine to umbilicus. So 1/3 divided into 1/3 and 2/3. So 1/3 point. Yeah, this 1/3 point is the McBurney's point. Okay. So from this, you know that there are three different type of appendicitis related issues we can identify. Now, how to go for retrocecal appendix, that is Schwarz sign. So what we do here, we passively Schwarz sign, you see iliopsoas is the muscle which helps in extension with the hip flexor muscle. Okay, so when you passively extend the hip, there will be tenderness in case of iliopsoas or tetrasical appendix. Okay, so what we tell, we ask the patient to lie on their left side, left lateral decubitus position, and with one hand we hold the patient right leg and passively extend the right hip by pulling the leg backwards. That is two times. Now, what will happen? This test will be considered positive if the patient experiences increased abdominal pain in the right lower quadrant. So, this is one of the standard method for eliciting iliopsoas pain. Okay. So, what is correct answer here? So, as you can see, as you can see from the options here. So place the patient in the left lateral decubitus position and passively extend the right hip. Option C is the correct answer. Okay. As you can see in Harrison also mentioned about three signs: Robsing sign, obturator sign, and Illusoire sign. So Robsing sign, what is it? It is palpating the left lower quadrant, which causes the pain in the right lower quadrant. It is known as Robsing sign. Obturator sign. So internal rotation of the hip causes pain, suggesting the possibility of inflamed appendix located in the pelvis. And extending the right hip causes pain along the posterolateral back and hip. It suggests there is retrosacral appendix. Okay. Thing is that remember, it is not definitive to call retrosacral appendix. It can be also seen in case of positive TB psoas abscess, or kidney is located in the same region, right? So perinephric abscess. Sometimes retroperitoneal hemorrhage will have positive result. Okay, all right. Now coming to the next question. A nurse in the ward has just completed IV fluid administration to a patient. After use, she removes the IV saline bag and catheter, both contaminated with body fluids. She asks where to dispose them as per biomedical waste management rules. Now, now if you see, there are four bags actually according to biomedical waste management. So something there is yellow bag, then we have the red bag, we have yellow bag, then we have the red bag, then there is white bag, as well as there is blue bag. Okay, there is blue bag and there is white bag. So let it consider to be white bag. Now, in which bag what to use for? So yellow bag is only for anatomical waste or human waste, or completely soiled ones. We go for yellow bag. Red is for contaminated plastic. So plastic material which are contaminated, we go for a red bag. Blue is for glasswares and vials, and white is for sharp. So here it is IV saline bag and catheter. What is IV saline bag and catheter? These are nothing but plastic. So IV set, catheter, all of these are plastic. So this contaminated plastic should be disposed in red bag. Okay. So answer here is red bag. Now another question about recent updates. So which of the following is false regarding Brensocatib? Okay. So what is Brensocatib? So as you can see, this is a new drug actually. So it is an oral reversible inhibitor of dipeptidyl peptidase 1, DPP1. Okay. So what does it cause? First, remember this drug, Brensocatib, with the name BR, is approved for bronchiectasis. Also studied for other diseases currently. It is studied for COPD but not approved currently. So it is approved for bronchiectasis. Number one thing that you should remember. Secondly, with name NS, remember it inhibits neutrophil neutrophil serine protease. Okay, neutrophil serine protease. Again, similarly, if you read from opposite side, there is Ne from the opposite. From it, you can remember NET or neutrophil extracellular trap. So as we are reading from opposite side, so what happened to neutrophil extracellular trap? Neutrophil extracellular trap decreases. How it decreases? By it reduces activation of neutrophil. So that's the mechanism. So what does it cause? It inhibits neutrophil serine proteinase. What happens due to it? There is decreased activation of neutrophil. What is the net effect? There is decrease in neutrophil extracellular tract. So where it is useful? It is useful in bronchiectasis. What it helps in bronchiectasis? It reduces exacerbation. It reduces exacerbation. Okay, it reduces exacerbation. Now, what kind of drug it is? It is DPP1 inhibitor. Important side effect that you should know regarding this drug is that that these drugs are known to cause two important things. One is skin infection, other is periodontal issues. So it is known to cause skin infection, skin reaction in the form of hyperkeratosis. Other thing that you should know, that it also causes periodontal reaction. Okay, periodontal reactions or periodontal infection issues. So these are the few points regarding this drug. It is approved for bronchiectasis. What it causes, it reduces exacerbation of bronchiectasis. Now this is studied for COPD too, but not approved currently. Studies are going on. It is a DPP1 inhibitor. Then it is inhibit neutrophil serine protease. So what is the net effect? There is neutrophil activation reduction resulting in decrease in neutrophil extracellular trap formation. Okay, all right. Now look in the option. So which of the following is false regarding Brensocatib? It inhibits neutrophil extracellular trap. So this is correct. It is true. Hyperkeratosis is a known side effect. It is again true statement. Inhibit neutrophil serine protease. It is also true statement. False here. It doesn't prevent exacerbation of COPD. It prevents exacerbation of bronchiectasis. The thing that is already proven. Although there are some rules in COPD too, but these are currently studied, not approved. So this is a very vague question. All of the four can be answered, sir, but better answer according to the question and the option here is option B. Okay, all right. So this was again another tricky question, little tricky question, but if you clearly, this can be solvable, easily solvable. So what does the question stem says? It says a elderly male with known ischemic cardiomyopathy and COPD present with ER with worsening dyspnea and orthopnea. So thing is that there is history of cardiomyopathy which is ischemic in origin as well as COPD and presenting with currently with SOP. So what can be the cause? So lung POCUS was done and you need to tell what can be the cause behind the finding. Now it can be both. It can be acute MI resulting into cardiogenic pulmonary edema, or it can be acute exacerbation of COPD. Okay. At this point, it can be anything with this history. And if you look into the lobar consolidation pneumothorax, this history doesn't suggest towards it, but also you cannot rule out this possibility. So, does the POCUS demonstrate? So there is multiple vertical hyperechoic line originating from pleura extend to the bottom of the string. So if you see this is the pleura, what is it showing? There is multiple vertical line which are hyperechoic. So what are those known as? These lines are known as actually B lines. Where is B line seen? B line is seen in the disease what we call to be cardiogenic pulmonary edema. Okay, so cardiogenic pulmonary edema is the answer here. Okay, cardiogenic pulmonary edema is the answer here. All right. Usually, when there is three or more B lines in the bilateral lung field, it becomes highly sensitive. Around sensitivity is around 97% for making a diagnosis. For it. Okay, for acute decompensated heart failure. What happens in acute exacerbation of COPD? Lungs are emphysematous. So there is less chance of seeing hyperechoic lines. Rather, there will be more of a hypoechoic lung shadows available. A profile will be seen in case of acute exacerbation of COPD. What happens in consolidation? In consolidation, you will get hepatization of lung tissue. Okay, no diffuse B line, vertical B line will be seen. What happens in pneumothorax? There will be absence of lung sliding. So lung sliding will be absence and A line will be there instead of B lines in case of pneumothorax. Okay, so answer here is cardiogenic pulmonary edema. Now coming to the next question. So here 40-year-old male. So 40-year-old male is presenting with chronic fatigue, unintentional weight loss, and generalized weakness. He reports significant dizziness upon standing. On examination, he is hypotensive and there is noticeable hyperpigmentation in the palmar crease. So there is hyperkalemia, hyponatremia, likely diagnosis. So what we are dealing with? So male patient, weight loss, generalized weakness, reports significant dizziness upon standing. What does it mean? It means orthostatic hypotension. He is overall hypotensive. There is hyperpigmentation. hyperpigmentation. And what does lab reveals? Increase in potassium, decrease in sodium. Okay. All right. What does all of this represent? All of this together represent the disease what we're talking about is disease of adrenal insufficiency. So this is nothing but disease of the adrenal insufficiency. Now question here is you need to identify whether it is primary adrenal disease or secondary, whether it is primary or secondary. What we call to be primary, we call primary adrenal insufficiency to be Addison's disease. Addison's disease. Okay. So if defect is at something high up at the level of the pituitaries. So if defect at the level of the pituitaries, it is the primary one. Primary one. So in primary, defect is pituitary. So defect is at the pituitary. Therefore, in primary, ACTH level will be high. Okay, ACTH will be high due to the defect in the pituitary. And in secondary one, uh, sorry, in primary and Addison's disease, defect is in the adrenal gland. So what happens when the defect is in the adrenal gland? So when there is defect in the adrenal gland, due to reflex action, ACTH level, ACTH level increases in from the pituitary. Okay. What happens in secondary? ACTH will be low because defect is lying itself in the pituitary. Okay. Now, thing here you need to understand here is that along with ACTH, POMC or MSH is secreted from pituitary. So as POMC or MSH is secreted from pituitary, which is nothing but melanocyte stimulating hormone, there will be hyperpigmentation. So single point which differentiate between primary and secondary is nothing but hyperpigmentation. Okay. So if hyperpigmentation is present, it is primary disease or Addison's disease. So it is nothing but Addison's disease because hyperpigmentation was mentioned in the question stem. Okay. All right. Now coming to the next question, it was also easier question here. So a biopsy from a patient with suspected IgG4 related disease was taken. It shows dense lymphoplasmacytic infiltrate. Which of the following histopathological feature is most characteristic? So it is nothing but storiform fibrosis with obliterative phlebitis. So you can see Harrison also mentioned like this. So hallmark histopathological characteristic for IgG4 related disease is a dense lymphoplasmatic infiltrate with mild to moderate eosinophilic infiltration, and this type of fibrosis is term of storiform pattern. Okay. If you look into the other options, what is causating granuloma seen? So one condition you need to know about causating granuloma, it is nothing but TB. One condition that you need to know about non-causating granuloma is nothing but sarcoidosis. Then regarding fibrinoid necrosis vessel wall, it is what does mean? It means vasculitis. So as IgG4 related disease, there will be storiform fibrosis with obliterative phlebitis. Now coming to the next question. So here 62-year-old male present with exertional dyspnea. Okay. And there is dry cough. Dry cough is for 1 year. He is a chronic smoker. On examination, bivessel fine and inspiratory crackles are here. Clubbing is present. Okay, clubbing is present. There is crackles present. Chronic smoker, exertional dyspnea. So this goes towards everything is going towards this dyspnea, crackles, and clubbing. Everything is going towards ILD, right? HRCT finding was also given. HRCT finding was also given, and PFT was given. So total lung capacity is 62% of predicted, which is reduced. DLC is 48% of the predicted. It is against reduced. What is the most likely diagnosis? Now, thing is that this pattern, basal and subpleural predominant reticular opacity, honeycombing with traction bronchiectasis, minimal GGOs. So all of these are pattern of usual interstitial pneumonia. Okay. So what was asked in the question, I am not sure. So if question is what is the most likely diagnosis, you see usual interstitial pneumonia is a radiological finding. So usual interstitial pneumonia plus clinical symptom of ILD. Usually after ruling out all the causes, answer is idiopathic pulmonary fibrosis. But if the question was what does this radiological feature means? So if this, what does this radiological feature means? Answer is nothing but UIP. Okay, it is UIP. All right. So what are the usual features? Usual features, as you can see from this recent table only. So there is traction bronchiectasis and honeycombing, which is a classical usual interstitial pneumonia pattern, usual interstitial pneumonia pattern. Whereas in case of NSIP or non-specific interstitial pneumonia, the pattern is GGO. So GGO is seen in NSIP. Okay. Okay, along with traction bronchiectasis. When there is diffuse patchy centrilobular GGOs, it is most likely respiratory bronchiolitis. All right. Now, even if you see the picture from the Harrison, in this first HRCT imaging, look carefully. There are a lot of honeycombing in the bilateral lung field. Honeycombing in the bilateral lung field. This is usual interstitial pneumonia pattern. All right. In the second image, what you can see in the second image, you can find there is presence of NSIP pattern. How NSIP pattern? Because there is something of a traction bronchitis like pattern. Okay, then there is some GGOs present here. GGOs are present here too. Okay, so it is most likely NSIP like pattern. What is the option C? So this option C here is actually, you can see patchy, sometimes migratory subpleural. So behind the pleural, subpleural consolidation. Subpleural consolidation. Where it is seen, this subpleural consolidation, it is seen in cryptogenic organizing pneumonia or COOP. Okay. Option D is nothing but a feature of sarcoidosis. So these sarcoidosis feature are very much non-specific. So coming to the question once again. So it can be IPF true. If diagnosis is the answer is true, it is IPF, idiopathic pulmonary fibrosis. You can see in the table, IPF have HRCT feature of UIP. If only the radiological finding was asked, so if radiological finding was asked, so answer will be usual interstitial pneumonia. Okay. NSIP, no. In NSIP, what is the pattern? It is the GGOs which is seen over honeycombing. And hypersensitive pneumonitis, again, it is not the answer. What is the pattern in hypersensitive pneumonitis? There is central lobar nodules, mosaic attenuation, and ER trapping. So mosaic attenuation, central lobar nodules, and ER trapping will be seen in hypersensitive pneumonitis. Okay. All right. Now coming to the next question, again from pulmonology section only. So which are the following PFT? So this is the last question we are discussing, 30th question of this INI-CET. So which of the following PFT finding would indicate the need for urgent further re-evaluation? So when do you re-evaluate urgently after PFT? After PFT is seldom diagnostic in case of COPD or bronchial asthma, right? Two important things that we need to differentiate COPD and bronchial asthma. So when do you need to re-evaluate? When the diagnosis is anything other than these two. So anything something of a serious. Say there is obstruction. So obstruction is given by this PFT flow volume curve. What is it? What you can see here in this part, you can see there is variable obstruction, usually above the thoracic inlet. Why so? Why so? There is plateau in the inspiratory phase. This part is the inspiratory, this part is the expiratory. So there is plateau in the inspiratory phase. In the flow volume loop, it suggests nothing but upper airway obstruction. Okay, all right. So usually it is seen due to variable extrathoracic obstruction, say vocal cord dysfunction. Therefore, laryngoscopy, direct laryngoscopy, and other methods are required to re-evaluate the case in such case of variable extrathoracic obstruction. So what is given by in flow volume loop? There is obstructive pattern. There is obstructive pattern with a flattened inspiratory plateau on the flow volume loop in case of variable extrathoracic obstruction. Okay. Now regarding the other options, so low DLC with restrictive pattern of spirometry, what does it mean? Low DLC can be seen in emphysema, it can be seen in ILD, it can be seen in pulmonary vascular disease in any of the cases, and these are expected abnormality here, right? So obstructive pattern with increased DLC. So this is classic obstructive and TLC lung capacity is increased. So what is happening? There is ear trapping. What does ear trapping occurs with obstructive physiology? It is due to hyperinflated lung. So hyperinflated lung is seen in COPD. COPD. Okay. Now obstruction, a disproportionate decrease in DLC with which it appearance on the flow volume loop. So obstruction along a decrease in DLC, it will be seen in case of emphysema. Okay, all right. So answer here is option C, obstructive pattern with flattened inspiratory plateau on the flow volume loop. So here come we have discussed about all the question regarding it, all those 30 questions. If you have not seen the first video, I'd request to go in a playlist and find the first video and obviously go and check this one. And one who want to join the course regarding the Harrison revision, which is a test-based discussion, link is given in the description. So we are going forward with this schedule. Once again, schedule is shared in the web page too, and you can join with us. Let's study and complete Harrison together in 6 months. Thank you.